listening to the Pharmacy Podcast Network. YARAL Pharma, an innovative player in the U.S. generics marketplace, has partnered with the Pharmacy Podcast Network to educate and build a network of pharmacists about non-scheduled, non-controlled prescription alternatives for pain management. We encourage feedback in establishing new connections with pharmacy care providers. Learn more at yaralpharma.com. That's YARAL Pharma.com.
Hey there. You know what? I'm excited about this particular episode because it's a design that I've had for quite some time. If you're listening to the Pharmacy Podcast Network, you'll know that we have themed podcasts that are designed for specific content: senior care, pediatric, specialty care, pain management. But what I really like to do is I like to fuse. I love to take two or three different hosts, two or three different subjects, and really bring them together. That's exactly what today's episode is about. And we have the one and only, the pain guy, Dr. Mark Garofoli, on with us today, who runs the Pain Pod, which is a big podcast on the Pharmacy Podcast Network. Mark, it's so good to have you here.
As always, Todd, always a pleasure.
And I just want to mention that Dr. Garofoli is not affiliated with YARAL Pharma. All of the views and opinions regarding pain management are his solely and are not attributable to YARAL Pharma. And we have special guest, Stephen Beckman, who is back. It's so good to have you back in the studio. It was great talking to you about innovation last time. I'm ready to jump into this here with you and Mark and really diving into the whole pain aspect.
Yeah, I have to say I'm starting to warm up to this whole podcast stuff, and what better way than to be able to have a dialogue with an expert like Mark. I think, like what we said on the last podcast, it's about raising the knowledge capital and educating and creating the awareness that allows people to make the best decisions. And ultimately, we provide a service, if you will, and providing a product to the marketplace. But it's people like Mark and as representing the pharmacy side and physicians that work together to drive forward the best treatment practices and regimens for their patients. And through their guidance and education, hopefully our products get put in the right place with the right patients.
Yep. Mark, we know the audience pretty much knows you. You are the pain guy on the Pain Pod. You've talked at Pain Week for years and years. I don't know how many years you've been doing that. But talk to us about your expertise specifically in pain management as a pharmacist, because that's extremely interesting to our listeners. There are listeners out there right now who are also leaning to the world of pain management. And they want to become experts. And so I want to start out there. Tell me about your background. How did you get plugged into becoming the pain guy?
Absolutely. And thank you, Todd. And hey, never, certainly don't assume, but don't presume that everybody knows everybody, right? There's new Pain Pod and Pharmacy Podcast Network listeners every day all across the globe, right? So how'd this pain thing happen? Started my journey with University of Pittsburgh School of Pharmacy, hail to Pitt. Let's fast forward. I also work at WVU, so walking back here at Brawl, but so is my wife. It's these things happen. It's a conundrum, right? But as far as the pain things, so my early career was in community pharmacy, as you know, but for everyone else, and really enjoyed being out with all the people. In the background, never really realized it, but really, really enjoyed education. Sounds nerdy, because it is. But, there's that element in the background. What do we do as pharmacists? Well, first off, we provide care. What was APHA president a good number of years ago? My favorite terms, so unspecific. Within the last decade, LB was the president when he said, you're in an elevator. What does a pharmacist do? We provide care. We also educate in the background. Yep. Take something hard, rough, complicated, and whittle it down, even for colleagues, not necessarily the lay public. It's almost like a shout out to the, what's that, I think 90s movie, Office Space, the guy that was between the engineers and the others. And he was a pharmacist. He didn't know it. Wasn't in the script. Well, you take all that, and then I worked within some medication therapy management efforts, some managed care efforts. Yeah, it turns out pharmacists work within those letters that I'm not going to say, insurance companies and whatnot. And all along the way, I mean, we got to keep this PG, right? Um, we got a lot of different fronts, but in the background, there was always pain management, there was always education. Then did a lot of different continuing education or CE presentations, found the calling, ended up with Western University School of Pharmacy. Been, loving it ever since. And now working, in our pain clinic, but then also teaching a whole heck of a lot, ranging from things like, your CV to heroin or meth or something like that in one of our new electives, substance abuse electives. So it goes all over the place, but the overall idea, it's like every school pharmacy has the quintessential P1 session where what can you do with your career?
Mhm.
And most folks walk into that thinking, well, I'm going to find I'm going to mirror that guy or that lady. Nope. All bunch of snowflakes. We're all going to find our own little way. There's no career route that's the same. So those that, want to become a pain guy like thing or a whatever else guy, you got to go out and make it happen, of course. Now, as far as the pain guy thing specifically, that was borderline having some humor, having some challenges among pharmacists. It was actually another pharmacy colleague and friend. I challenged her to do a TED Talk. She challenged me to get a trademark. In the end, we all win. Yay. And here we are. So that's the very succinct yet a lot of bandwidth journey.
Well, I want to turn things over to Steve because I really want you to dive in and take advantage of the expertise that Mark brings to us and our listeners today, which is really centering around pain management and how YARAL Pharma, as an innovator in the products that you're doing, the patches that you're providing, is really making a difference.
Great. So, hey, first question then. So, obviously, we want to talk a little bit about topical pain management. So could you explain why topical delivery of pain medication is an important option for patients, pharmacists, and physicians to consider?
Well, as a human being who's been in pain, you want every option that is safe and effective readily available for you, within reason, of course, but the more options, the better. So, in a patient-centered, patient-specific realm, it's really important to have all types of options, not just medications, pills, tablets, capsules, so on and so forth. You got to have the whole realm overall. And that's not even diving into what specific medications I have a feeling we'll talk about, but it's really just having diversity along the way.
Well, Mark, I have to tell you, you scored big with me because I think that's very consistent with our past podcast, which is you have to have the options so that the options can be applied to the right situation and to the right patient. So what role can pharmacists play in educating patients about topical pain? Is there anything particular that comes to mind regarding the role that pharmacists can play?
I would even twist that to say what pharmacists are playing or will.
Good.
Let's amp it up here. The overall idea of, I think I opened up earlier with the whole pharmacists provide care, and in the background we educate. It's quintessential when you think about it. Well, you're talking about medications. Who's the medication experts? Ding ding.
Hello.
That's us. It's so easy to talk about hundreds of thousands of people in a limelight in a good way, and that being licensed pharmacists, of course. It's a no-brainer that it comes into play for who's going to be out there educating. I often I love interprofessional care and education, and I just love having a good amount of diversity in the room. I usually never take a stage without asking, hey, who's in the audience? I mean, golden rule, right? Like, know your audience. Kind of hard to do on a podcast, by the way. But anyways, so who's ever out there, keep listening, right? The general idea is, the room is just better when there's more diversity out there. But when it comes down to it, who's got medications in their realm? I mean, that's the whole interprofessional care team, but that's us. That's where we are accessible as well. In working very interprofessionally, I challenge other professions to say, call yourself, literally. Like, just try and access yourself in the office, the clinic, the whatever. And by the way, pharmacists, that's us too, because sometimes those phones are ringing. But try and call yourself. That might not work out. Might work out. Yeah, positive, glass half full of something. But who can you walk right up to and just ask a question? That's us. And that's really where we come into play.
Yeah, it struck me. I've been in this industry for over 30 years. And of course, we always think about physicians and pharmacists. And obviously, physicians have to understand medicine to a point because they're the one dictating, treatment regimens and maybe initial treatment selection. But at the end of the day, it's really the pharmacist that, ends up being the true catalyst to making sure that translates well, or clarifying questions for patients and things like that. So, as I said earlier, I think, pharmacists will continue in many ways to be such an important, and always have been, but hopefully be recognized a little bit more in terms of the important part that they play in that whole mix. So in talking about, topical patches, we have a product that we currently market, which is Diclofenac Epolamine patch, topical patch, 1.3%, for acute pain, and would be interested to see your thoughts on the role of this particular product in the mix, or within the bag of options that physicians and pharmacists have for their patients.
Absolutely. If there's one realm that is often overlooked, or doesn't just demand or get the amount of time that's demanded to understand, it's really topical medications overall. We could hone it in certainly for pain management. Of course, our conversation here today, but I previously was talking about how we pharmacists and pharmacy professionals overall are the most accessible. That's wonderful. And then it's okay having this information and working with it. When you walk down an average pharmacy aisle, I always encourage pharmacists, pharmacy technicians, family, friends, whoever, to just go for a walk. It gets complicated. That's the OTC section, of course. Pharmacy is pretty complicated too. How do you wrap your head around all that? And that's where that education side comes in. We're talking about topicals, and I've been invited in other accords to do presentations and education when it comes to how do we wrap our head around this? There's so many products. And it's really just, grouping things together to have a starting point. There's counter irritants. You got your things that are going to warm things up and things that will cool it off. And sometimes we combine them, warming things, methyl salicylate, capsaicin, and so on, cooling things, camphor, menthol, all that great stuff. I believe mentioned lidocaine. That's an option. That's of course, going to go in the numbing agent realm. And then any inflammation, things like diclofenac, you mentioned a product as well. It's really not only having that access with pharmacists, but then us being able to wrap our heads around the twofold of what are the ingredients, what are the treatments, and then what products are available as well too. It's a tough landscape to navigate, really. So
when you think, a couple questions come to mind. One is the relative role of products like this in relationship to opioids, or and how pharmacists and physicians should be thinking about how do you approach making those decisions about how to use one product over another, and how important, and the second part of the question is how important it is to really have options like topical patches as an alternative than having maybe to bring out the big guns right away. And not only the opioid crisis, but just, going forward, how do you think about that, and where the role of a product like this plays?
it's, it speaks volumes to what we were talking about earlier of the just making sure that you have the right tools in the toolbox. The society that we live in, we have the opioid crisis, opioid epidemic, the opioid everything, all sediments and all that. There's a lot going on. Those are 15-hour conversations in themselves.
Mm-hmm.
But in the big picture, if you take a balloon, let's say it's water, hopefully it's summer, and you squeeze one side and the other side, well, that might, everything goes over to that side. So if we clamp down on opioid utilization, like guideline efforts, organization efforts have attempted or at least aimed to do in the last few years, even the last decade or so. Then what else? Okay, well, let's take a different realm. There's the Beers criteria. Okay, get your minds out of the beer cave in West Virginia. The Beers criteria for geriatric care. Okay, we don't do beer shops, liquor shops, all that. You go to the grocery store. Anyway, that criteria, when you look at it for pain management, darn near everything as far as the treatment option is on there. Sans, maybe paracetamol, acetaminophen, but hey, you got any liver things, that'll come into play. And topicals. So there's so many things eliminated from the realm given the typical patient scenario. So back into regular realm for those that are elderly or not. When you clamp down on one thing, you got to have some other options around. And even if utilizing the other, agents along the way. So it's just really important to think through what are my options. It's like a multiple choice question or a word bank for a word search. If you're doing a word search and you don't have a word bank, a little bit tougher. You got to remember what is in your word bank, your toolbox for pain management along the way.
So to build on what we just talked about, what is the current state? Well, we kind of talked a little bit about what the current state, but what is the current and or future state then of topical pain options, given some of the dynamics you just talked about? How should a pharmacist think, or how should we think about where topical patches should go? So if they have to modify their overall management and they're going to different things, how do you see topical patches evolving in terms of, the current state of affairs, if you will?
It seems like, certainly observationally, anecdotally, but in talking to a lot of prescribers, dispensers, experts, and all that all across the country, it seems like we're expanding our minds a little bit, broadening the horizon to think, globally. You could look at, I've had numerous folks in a global sense ask, Mark, what is the deal with our country with not opening up to these other things? Topicals, whatever else. And it's like other continents, most of them, down with this stuff from centuries ago, or decades ago, depending on approvals, of course. So why does it take us longer in this realm? It's just a different culture, different society of pill for every ill, and then an ill from every pill. Those days of more polypharmacy are slowly coming to not an end, but at least a plateau of trying to, not add on. And it's really important to as clinicians out there, especially, to remember that there are these options, and that's happening more. We don't have floodgates opening up, but it seems like folks are really looking at other options, whether it's out of the propensity from other things clamping down, like we were talking about, or just the reality of, this has been sitting over here the whole time. About to pay it some respect and have it as an option.
So I want to circle back specifically on topical patches for a minute, and I guess the question is, when you look, like, when we market products, we always talk about features of the product and the benefit that feature translates to a patient. So when you think about the following things like mess-free, localized absorption, non-habit forming, so when you use these criteria, or maybe something you have in your mind, what's the most important, or what's the value, or maybe even the ranking in terms of how patients might see the benefit of a topical patch?
It's being patient-centered is not only a buzzword these days, but incredibly important. Just because it wasn't a buzzword 20 years ago doesn't mean it wasn't a thing. In talking with patients, one of the most important things is we need to learn about your life. What do you have going on? If you're going to be asking someone to apply something, say a topical gel or something, and maybe it has a scent to it that isn't all that pleasant to 99% of people. If you're asking someone to do that multiple times a day, and they have 2 jobs, 2 kids, half a car, and there's just a lot going on, or maybe they're a CEO. I mean, I'm sure you're busy. It's both of you, actually. It's just tough. It's like telling somebody to take a medicine. This is this is off key, but telling somebody, oh, take that statin, we'll say, take that statin at bedtime. Phenomenal. It's going to work better. Okay, well, that's when I'm falling asleep. It's
Yeah.
actually a lot harder than, to just say something is one thing. To be like, how are you going to do that? It's going to be by the nightstand or something. Let's go back into pain here. The when saying, oh yeah, just apply this 4 times a day. Well, think about that. Like when? I mean, are you in the bathroom at work? Compared to say, okay, busy lifestyle, maybe patch comes into play where, this isn't a rotisserie chicken. You don't set it and forget it. But like, compliments to Ron back in the day. But it's those patient factors that come into play that, convenience, the age old finger cut situation of, what's the Will Ferrell philosopher thing of what you do with your hands. So if you're touching creams and all that and you touch your eyeball, we learned a few short years ago that people are always touching their face. Yep. It's an issue, particularly if you have something that'll burn your eyes in there. So those patient-centered factors are really practical and important. And if we as clinicians put ourselves in the role of the patient, it becomes evident really quick.
Mm-hmm. Well, I think that's pretty insightful. And I think ultimately we all probably think we do, but the question is you always have to step back every once in a while and observe yourself if you actually are doing that and thinking as if you were the patient. And thus I think you hear them better, and then thus you have the better direction and guidance and education. And I have to say, I like you even more now because I'm a big Will Ferrell fan. So anybody can
I had a
gets this extra bonus points from me.
Folks, he has a pulse.
Let me shift back to administration for just a second. Let's talk about an operation on someone's femur, right? Bone broke, they got it set, everything's fine, cast, or blah, blah, blah. Now the cast comes off, things have healed nicely. They're still experiencing some pain, right? Where does and this is definitely for Mark, where does the patch come in as a favor with someone like you, Mark, who is a pain specialist that really has thought about different kinds of pain? Where does the patch rise to the top of opportunity versus if I just had that same surgery on my knee, I'd start maybe an opioid, because it's super intense versus versus a patch that goes on my skin that goes on top. Is there like a best scenario to use a patch versus another form of pain medication?
You know how to ask the complicated questions, don't you?
Well, you've had the chance to listen to us for the last 20 minutes, so he's been forming since the beginning of the podcast.
If I can make a Rubik's Cube question.
There you go.
Oh, I got one of those electronic Rubik's Cubes. I really want to figure out being able to do that pretty quick. That might be easier than approaching this question here. So what we're looking at is saying like, okay, here's a very specific situation, but apply it universally, which is the point that I'm trying to chat through here. There's a place, of course, and it depends on what the patient has going on. Now, Todd, I got to call you out. You mentioned, so I went and I got this opioid. Where'd you go? I'm not asking for me. I'm either asking for a friend or for the audience. Because seriously, the last time I went to a hospital and I was in incredible pain, it took me 3 hours to get something. Sitting on the gurney as pain guy, by the way. We have defaulted as a healthcare society to, one extreme to the other and give it 7 years. We'll be back again. But along the way, there's going to be patients where they're in a scenario, perhaps like you mentioned, it's an acute situation or acute on chronic would be another way to say something or whatever. But, we're not talking chronic pain here. But these scenarios arise and it's, the clinician taking that extra couple seconds. I mean, literally, it's not minutes to think, okay, in this situation, what are my options, both medication and formulation, ingredients and what types. And all too often, the formulation part gets tossed to the side because we are a society in general. I'm not making anything up here on the pill side, but, that comes with baggage. There's a little bit less baggage with topical agents just in general, because you're just not getting that systemic absorption overall. there's a million studies out there. Of course, every product has its approval studies, but generally speaking, you're not going to have that very profound concern, systemically speaking. So in those scenarios, as long as the skin's not open, there's not that, and concerns there for, cuts or anything like that, then certainly a topical, something like a patch could become an option that makes that patient's life a lot easier for the next couple of days, and hopefully better, the efficacy part.
So I want to try to add on to that question that Todd just had. And so, because as you were talking, one of the things that I was thinking about was topical patches, provide controlled release medication, right? And maintain optimal concentration. So how do you look at that as a potential feature of the product in terms of how you see it as potentially being a benefit to patients, or how important that is in managing pain too? Because obviously there can be inconsistencies of management based on what the patient does or not wanting to do. I guess your example of gels or creams might be one. And then maybe there's an inconsistency of that medication. So any thoughts on that particular topic about the fact that by virtue of how it's delivered, it is controlled and concentrated or sustained for the period of time that the patch is indicated for? In case of, Diclofenac patches, 12 hours, or there's a 24-hour patch as well. Any thoughts on that?
It's very important in the big picture. Almost like the no-brainer of eliminating more opportunities for error. There's just in general, there's medications, topical ones that'll come even with instructions explicitly how to use things. And then here's where I'm going to rock out the academic in me. Even though as a student pharmacist, I never thought that would happen. But we recently did a study there. It had to be said. We recently did a study, and I got called out by a lot of other pain experts. Like, Mark, what the heck are you up to? This was a couple years back, and they're like, not only is there a pandemic, but there's the opioid crisis and everything going on in the background. And I was like, let's study what people know about over-the-counter pain medicines. And that's where everybody was like, what? Like, everybody's studying opioids and the effects and all that kind of stuff. I'm like, well, there's like 50,000 people a year that end up in the ER from good old over-the-counter things. You got to take that into play. So what this study had shown, basically, because we incorporated having high school students involved, they received education, and then they did screening out in the community. They certainly couldn't provide education. I mean, you're not even talking a licensed pharmacist. They're lucky if they're licensed to drive even, to just provide, hey, if you answered yes to this question, then talk to your healthcare provider. And more often than not to summarize an entire publication, but, like 7 out of 10 times, the exact opposite of the Baseball Hall of Fame, 7 out of 10 times, somebody would be like, they didn't know anything applicable about the over-the-counter medicines. So you put that into the realm of topicals even, and it could become a free-for-all there of just, you can hear the directions. You could even the talkback method of saying, oh yeah, that's what you told me. But then, 6 hours later, when there's a kid crying or there's 7 job duties that are due, it's a little bit tougher. And really doing anything we can in that realm to just help the patient overall in their life, make things easier, and still have that safety and efficacy as FDA-approved products. That's an important thing.
So Mark, a question I would not even thought of until you started talking on that last response, and that is pain management's an important thing, right? It's obviously an important topic when it's misused or the history that we've had with the opioids has been raised. But I guess the question for me is, when you think about pain management, is this something that really has to start with a dialogue with the pharmacist or physician? Because I guess what I'm saying is, now I'm concerned that I would even think myself to go in and self-medicate using even an over-the-counter pain medication, and that's really not where you should start. The conversation needs to be above that. Maybe the question is that the guidance is to go back to an OTC, but I guess what's your philosophy on, should whatever pain, should should that person be talking to a pharmacist or physician first, or do you feel it's okay to start your way up maybe from an OTC? Because it seems to me there's a lot of variability that can happen if it's in the realm of managing pain if we leave it to our own devices, so to speak.
It's hey, we're all human. We're mostly adults and and some professionals too. People are going to make their decisions, of course. The availability is typically there, but anymore, most folks want things, electronically and all that great stuff. But in utopia, folks would talk to a professional or two, get advice, and go from there. Um, but the ease of you're already out shopping, somebody's at a let's not even say pharmacy or grocery store for that matter, dollar store, gas station. Um, somebody's out playing in a park and hurts their ankle. The availability and meshing that into their life of wanting to continue on a wonderful day with their family or friends or whoever, and that's just not there all the time. So it's going to be self-driven in many accords. But in utopia, it would certainly be, am I going to go mess with my car or am I going to talk to the mechanic first? Well, probably neither, because I'm just going to know to stay away. But if I had to, it would behoove me to, call an auto shop first and say, hey, what am I getting into? Same thing for plumbing or whatever, in case anybody's, flooded their house. Thankfully, not myself. It's always best talking to a professional, if not more, first. It just isn't going to fit into every situation, of course, too.
And that makes sense. But I think
good question, though. I love where you were thinking there, though.
Thank you. I try to come up with at least one good question a day. But I think your sentiment makes sense. I mean, I know that I will not do plumbing and I won't do electric in my house because one, I'm afraid I'm going to burn it down or flood it. So the theme is that, all right, in certain circumstances, you might not be in a position, but when you are in the position, especially when it comes to pain, asking an expert first, like a community pharmacist or so forth, is a great place to start. So absolutely. I know I have one more question to kind of round up. I don't know what else Todd might have percolating in his brain here. But maybe a good way to conclude the podcast is the following, is that the question around future developments in pain. If you were to think about what you are seeing or what you'd like to see, what kind of things, if you were start to map out the next few years in pain, because I think that would be a good insight, not only for pharmacists, it'd be actually really good insight for me. Right. Might be something that we should be thinking about from a development standpoint. So, when you think forward thinking now about pain management, the trends that we're facing now and how that will evolve going forward, what should we be thinking about collectively? I mean, physician, pharmacist, developer, so that we can continue to work towards solutions that continue to better fit the patient need.
I love that question, and we've had it for a long time. In the pain realm, I don't think I'd be alone in saying, I know I'm not alone in saying that, it's been the quest for the Holy Grail. And we're not talking about Monty Python and the guy at the bridge or whatever, but you want safety, you want efficacy, you want your cake, you want to eat it too, you want it to not have any diversion, misuse, abuse concerns, you just want the thing to work, you want probably no side effects, which, good luck for anything. We want it all. We have yet to come across that holy grail per se in pain management. So the question of will we get to it is, it's kind of like predicting the lottery. And I don't even buy tickets because I hear that people get very unhappy when they win billions of dollars. Doesn't make sense, but I guess so. What would be great for the future? Well, moving along those lines, we've had a small number of, novel pain medications come out. And sometimes they end up with huge contributions in utilization. And sometimes it ends up being more textbook of, new mechanism of action and, beautiful video from wherever, or, the TV ads with kayaking and everything else. But in looking towards the future, it would be great to take some of those elements of the Holy Grail and just say, okay, would we be able to devise novel medications for pain management that wouldn't really have as many concerns for the misuse, abuse, diversion, so on and so forth. Probably can't eliminate everything, but at least limit, and then have that safety and efficacy. Have it be in a dosage form that's applicable to anyone's life, and to be able to get it done in the end. There's already our phase 1, 2, and 3, but phase 3 studies completed on a good number of different novel medications, extensions of current mechanisms of action, sometimes new mechanisms of action. It would be great to have new things, truly new, not just another Me Too, along the way. Unless things are really, truly, when you change a formulation, it becomes easier. How many times a day is something utilized, applied, whatever, really comes into play as well too. So I know a lot of folks know of what's on the horizon, but as far as designing it, that's going to be for the guy or gal at the computer that's using AI to make these new chemicals along the way.
That's right.
Everything like that. So I have no investor advice for you, but I'm sure you have a team for it.
Well, what I like to do is surmise maybe that, Mark, and say what I heard from you is, look, at patients are different, pain is different, situations different. Thus, we need multiple options.
Yep.
And hopefully at the end of the day, those multiple options, through the advice of the physician and pharmacist, will be applied to the right patient at the right time. And even if we get new novel therapies, they still probably will never achieve this utopia of working for all, because there's just too much variability in those things I just mentioned, type of pain, length of pain, patient tolerability to pain, all those different things. And thus, ultimately, which I hope that's what we are delivering at YARAL, is one of those solutions when it's appropriate for that particular patient. That fair?
Yep. The true win is just expanding the toolbox with something truly novel.
Well, pleasure.
This has been great. I've been looking forward to this episode with you, Mark, fusing you, like I said at the beginning in the opening, with other subject matter expertise. Steve, you've been a conduit of incredible information for us and our pharmacy listeners. Listeners, if you'd like to learn more, I want to direct you to yaralpharma.com. That's YARAL pharma.com, and you can read up on the products that are available. But as we said in our last podcast, we want to be a resource for providers. We want to be a resource for our pharmacists and physicians. So if you want more information from YARAL Pharma, their teams, their research, white papers, whatever you need, please reach out to us. You can reach out to me at Pharmacy Podcast. You can reach out to Steven, who's on LinkedIn. You can go to the website. And also check out the Pain Pod at painpod.us, which is Mark's ongoing side hustle, pain podcast that's out there. And listeners, you're the ones that are making this network incredible. All of my podcast hosts were listeners first. So if you have something to add to this network, please do so, because we rise together. And I always say #TogetherRx. So with that, I want to thank you guys for listening. And Mark, thank you so much for being a wonderful guest today.
2 thumbs up. Thank you both.
Take care.
Talk to you next time.
Diclofenac Epolamine Topical System 1.3% is a non-steroidal anti-inflammatory drug, NSAID, used for acute pain from minor strains, sprains, and bruises in adults and children aged 6 and older. Serious side effects may include increased risk of cardiovascular and gastrointestinal events. NSAIDs can raise the risk of heart attack, stroke, gastrointestinal bleeding, ulceration, and perforation of the stomach and intestines, which can be fatal. The risk for serious cardiovascular events may occur early in the treatment and may increase with duration of use. Elderly patients and those with history of peptic ulcer disease or GI bleeding are at a higher risk for serious GI events. Do not use in patients who are allergic to diclofenac or any of its ingredients, or have a history of asthma, urticaria, or other allergic type reactions after taking aspirin or other NSAIDs. Do not use in the setting of coronary artery bypass graft surgery. Avoid use on broken skin. Discontinue immediately if signs of hypersensitivity occur. Patients should be informed about the warning signs and symptoms of liver problems. Discontinue use if abnormal liver tests persist or worsen, or if signs of liver disease develop. Avoid using Diclofenac Epolamine topical system 1.3% in patients with severe heart failure unless the benefits are expected to outweigh the risks. The common side effects include itching, nausea, and headache. Patients should stop use and consult their doctor at the first sign of skin rash or other signs of sensitivity. Patients should ask their doctor if Diclofenac Epolamine topical system 1.3% is right for them. For more information and full prescribing information, including boxed warning and important safety information, visit www.yaralpharma.com. Lidocaine patch 5% is indicated for relief of pain associated with postherpetic neuralgia, a common complication of shingles. It should only be applied to intact skin. Lidocaine patch 5% is contraindicated in patients with a known history of sensitivity to local anesthetics of the amide type or to any other component of the product. Cases of metemoglobinemia, a rare blood disorder that affects how red blood cells deliver oxygen throughout the body, have been reported in association with local anesthetic use. It is important for patients to store and dispose of lidocaine patch 5% out of reach of children, pets, and others. Applying lidocaine patch 5% to larger areas for longer than recommended wearing time could result in increased absorption of lidocaine and high blood concentrations, leading to serious adverse effects. Patients should avoid contact with water, such as bathing, swimming, or showering. Reactions may occur at the site of application. These reactions are generally mild and resolve within a few minutes to hours. Allergic and severe allergic reactions associated with lidocaine, although rare, can occur. Patients with severe hepatic disease are at greater risk of developing toxic blood concentrations of lidocaine because of their inability to metabolize lidocaine normally. Advise patients to discontinue use immediately and seek immediate medical attention if the following signs or symptoms occur: pale, gray, or blue-colored skin, cyanosis, headache, rapid heart rate, shortness of breath, lightheadedness, or fatigue. Patients should ask their doctor if lidocaine patch 5% is right for them. For more information, including full prescribing information and important safety information, visit yaralpharma.com. Levothyroxine sodium capsules are L-thyroxine T4 indicated for use in adults and pediatric patients 6 years and older with hypothyroidism. Levothyroxine sodium capsules can be used for pituitary thyrotropin, thyroid-stimulating hormone TSH suppression. Thyroid hormones, including levothyroxine sodium capsules, cannot be used for treatment of obesity or for weight loss. Doses beyond the range of daily hormonal requirements may produce serious or even life-threatening manifestations of toxicity. Levothyroxine sodium capsules are not indicated for suppression of benign thyroid nodules and non-toxic diffuse goiter in iodine-sufficient patients, or for the treatment of transient hypothyroidism during recovery phase of subacute thyroiditis. Levothyroxine sodium capsules are contraindicated in patients with uncorrected adrenal insufficiency. For elderly patients and those with underlying cardiovascular conditions, starting with a lower dose is recommended due to the heightened risk of cardiac adverse reactions, including atrial fibrillation. Oral thyroid hormone drugs should not be used to treat myxedema coma, and replacement glucocorticoids are necessary for patients with concomitant adrenal insufficiency before initiating levothyroxine sodium capsules. To prevent hyperthyroidism or for incomplete treatment of hypothyroidism, proper dose titration and careful monitoring are essential. Diabetic patients should carefully monitor glycemic control after starting, changing, or discontinuing thyroid hormone therapy, since glycemic control may worsen in diabetic patients. Decreased bone mineral density associated with thyroid hormone over replacement may occur. Adverse reactions associated with levothyroxine sodium capsules primarily reflect symptoms of hypothyroidism due to overdosage, including arrhythmias, heart attack, dyspnea, muscle spasms, headache, nervousness, irritability, insomnia, tremors, muscle weakness, increased appetite, weight loss, diarrhea, heart intolerance, menstrual irregularities, and skin rash. Patients should ask their doctors if levothyroxine sodium capsules are right for them. For more information and full prescribing information, including boxed warning and important safety information, visit www.yaralpharma.com.